Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James. Today I'm joined by two guests, Dr. Ben Jackson and PA Javi. Welcome to the show, both.
Hi James, thank you for having us.
Hi James, thank you very much for having us.
Javi, do you want to introduce yourself first?
Yeah, hi, my name's Javi. I'm a PA in primary care in Sheffield, and I'm also a PA lead for South Yorkshire and Bassetlaw and lead on the South Yorkshire and Bassetlaw PA preceptorship scheme.
And Dr. Jackson?
Yeah, my name's Ben, and I'm an academic GP from South Yorkshire. Was involved in setting up our PA course at Sheffield University, and still have workforce roles within the region. And I'm currently, it's led me to pursue a PhD in looking at the supervision of new roles within primary care.
Thanks, both. So the reason I wanted to get you on was to talk about this really sort of innovative and really brilliant preceptorship program that you've been developing for your area in Yorkshire, and the level of support that you are offering the physician associates who are new into primary care. Javi, do you want to sort of explain how that sort of came about in the first place?
First stage is that the South Yorkshire and Bassetlaw hub were advertising for actually a PA to help run the scheme. So I thought, that'd be quite a good opportunity. So thankfully I managed to bite off some people and they offered me the job. Looking at the scheme, I think one of the interesting things was the challenge of bridging a PA that's newly qualified to the demands of being ready and fit for practicing. And for me, there wasn't anything in between the glue to really stick it together. And I think in the scheme, what we did is we did a lot of preparatory work at looking at where do you need to be and what are some of the deficiencies that the two-year educational program doesn't necessarily provide. Just to give you a bit of a rundown about our scheme. So usually what we do is we actually now take them in cohort. So we're just about to start our second cohort. So we do it roughly in autumn, October, November time, where we'll run a 2-year training program. So we're mainly responsible for the educational element, but I feel quite responsible to equip the PAs with some other aspects in order to give them a holistic understanding and training of primary care. So what we've done is we've actually created an extensive handbook for not only the new PAs, but also the supervisors. It's not too extensive, but it's a breakdown of what the expectation is for both people in the first 12 months. So it's a case of debriefing, supervision, how long should appointments be? And some of it's been taken from some of the things that are out there, but some of it's been done by actually discussing with GPs that are in training programs about what they found useful or not. So it looks at that. It looks at, what are some of the most common conditions going on there to give people heads up? What are excellent resources for people to look at? What should PAs be doing? So that's the handbook. That's one of the things that we do. We do weekly teaching sessions as well. We do give people time off during holiday seasons, but we cover a wide variety of topics. But I've worked on this scheme also with two other doctors, Amanda and Rob. And what we look at is teaching that's specific to primary care. Because sometimes what I found is you might get consultants in from hospital who are fantastic and teach you lots of interesting stuff. But really in your training program, things that are relevant to GP. So for example, if we did get people from specialities, we'd get registrars. And as part of the teaching program, we'd want them to be like, well, actually, what do you care about when you want someone referring in? How do you like it? What do you worry about? What don't you worry about? We wanted to provide a really comprehensive, holistic package of teaching. And what I mean by that is, for example, some people are expected to go to nursing homes, but you don't get taught that. Really, geriatrics isn't covered that well. So we cover people with nursing homes, palliative care. We've even discussed topics like human trafficking, modern slavery. And in year 2, as well as covering all the core conditions, we're looking at things like imposter syndrome and a variety of other things around that. Because like we said, we're looking at creating holistic practitioners. Because at the end of the day, we're expected to perform at quite a high level, but you need a training program in order to meet that.
it's a real challenge for the physician associates who go straight from graduation into primary care. The strong messages are that dealing with the breadth across and the complexity is really quite a challenge. And what's great about this is that, of course, there's clinical supervision in the workplace, which is very, very important. And we might go on and touch about that, about safety and about debriefing and things. But one of the most important forms of supervision when you're a new practitioner is supervision with peers, where you go and you benchmark where you're up to, what types of jobs that you're doing. And actually that reflection that you do on preceptorships like Javi's, where you're actually thinking, well, how am I developing this professional role? It's so important for you to actually understand where you're going to end up. And the other thing that's so important about what Javi says is that there's always this phrase that your competence in clinical competence is context specific. So you might be competent in one context, but that doesn't necessarily mean if you lift it and put somewhere else, you feel confident that you've got the skills. You may have some. And the way that Javi's recognising that even within the cohort in South Yorkshire, PAs will be having very different roles because every practice is different, and starting to listen to the PAs across the region and deliver what they require rather than some sort of top-down, this is the handbook for primary care, is really, really important, I think.
Yeah, and just to add some other stuff that we've got that I'm quite excited about, newer developments on our scheme. We've worked with 14 Fish to actually develop a portfolio and appraisal toolkit. Previously, when I started, we were just using the paper that was handed by FPA. And I think that could be quite frustrating for a lot of supervisors and very 20th century. So, yeah, we worked with 14 Fish, and actually people on the preceptorship have all been given access to a portfolio that looks at, mini kexes, COTS, various different forms of assessments, and just, bringing it up to the modern world. And I think the other thing we like to do in our scheme is it's not just about the teaching, it's probably a lot about debriefing together and providing that support. So we try and fit in every 6 weeks a debrief session where people have cases that they want to discuss or challenges that have been going on, that we can actually provide that forum with expert clinical professionals to actually discuss that. And, we at the Hub would be really happy to work with other people in other parts of the country and hear what they're doing. Because I find when we're first setting it up, everything's really sporadic. You've got bits of best practice here that people don't know about, bits down here. If anybody hears this and they want any help or ideas, we're always here at South Yorkshire and Bassetlaw Hub to help and share ideas.
I have so many questions to ask you guys. To your point, I share your frustrations. We're all developing these things in silos across the country, and I'm talking to other people, hearing of doing other things that are similar and some that are different. And to your point earlier, Dr. Jackson, about the course is a generalist course. We all go through 2 years. It's quite heavily skewed towards secondary care. The amount of time that you get in placement is heavily skewed to secondary care. The skills that you're learning, like catheters and ABGs and things, are things you'll only do in secondary care. So I know when you were designing your course locally in Sheffield, you spent a lot of focus on thinking about what primary care clinicians would want from their physician associates as they graduate from your course. Can you tell me a little bit more about how that influenced the design of your course?
In a nutshell, we've put a lot of emphasis on clinical reasoning. And so there's a core that goes right through the 2 years, which looks at, as you're learning the clinical information, you're also learning how to use it. Now, clinical reasoning is something that's taught a lot in medical schools, but we hadn't seen it so much, so emphasised in our physician associate courses. So we put a lot of clinical reasoning in there. We also, within the guidance, expanded our placements to that first contact as much as you could. We gave the maximum amount of time in primary care. Where we had to use hospital placements, where we had to do the general medicine, we ensured that as much as possible of that general medicine was in the acute medical unit. So we tried to put the PAs right the way through the course, where they were dealing with first contact of the symptoms, and then work with them about how they worked with those symptoms to try and create the problem solving, the diagnosis and the management. That clinical reasoning wasn't just the diagnostic clinical reasoning. It was that shared clinical reasoning with patients. So similar to, we did a lot about the communication skills, but not about the communication skills which you use as a tool to use your clinical knowledge, but actually about what we call the clinical communication skills, how you actually integrate your clinical knowledge when you're talking to patients. So we sort of bulked out the primary care element, and then we dealt with that. And of course, the other thing we did is a lot of preparing the physician associates and I think a lot of courses do that, for what that new role was. But we also did a lot of the teaching was from general practice. We had all the ILAs were taught by GPs, so we made sure that they had the generalists who were actually teaching them as well. And that's changed a little bit since we started it, but overall that's what we did. I don't know, the important thing that comes out when you're talking to supervisors of physician associates about the clinical reasoning is about trusting judgment. And what the supervisors often say is that they're looking for whether the new practitioner, the new physician associate, is thinking about what they're finding. So what can happen if a new physician associate simply reports the information that they've got, either history and examination, but doesn't then go the one step further and offer suggestions, options, possibilities, thinks a little bit about what fits, what might not fit, then that leads to a sort of almost a stagnation of development, because they then have to sort of transfer a lot of that sort of cognition, which is hard work at the end of a morning. And it's a sort of half removed clinical reasoning, and it's really difficult to do. Whereas if the new physician associate comes and provides their thinking, then they can actually that's how they get to trust whether they'll know their scope. So that's very important, and that's something which we'll hopefully be, Javi on the course will be discussing, with how to be a good supervisee as well as how to be a good supervisor.
One of the things I thought it would be worth talking about is setting, from your experience, some expectations for any GPs out there who are listening to this, who may be considering employing their first physician associate into their practice. I hear some horror stories sometimes of what my PA peers go into and what they're expected to do on their first day, which is totally unrealistic. Could you, maybe Dr. Jackson, just say a little bit about what is appropriate for a new PA as they graduate from school? Yeah,
what I'm going to say, I think, is that you're right. I think one of the issues is that still the physician associate role is an emerging role, and many GPs are unfamiliar with the role. And of course, with the additional roles reimbursement scheme and the network contract, physician associates are one of the roles that practices are looking for to support them and support their workforce. But the GPs are unfamiliar with what that role is. And if they're not training practices, they're also unfamiliar with how to supervise somebody, debrief somebody who is new to practice. And they may have taken on younger doctors, and they may have nurse practitioners. So I think that's a really good question, but it's probably better for Javi, who's a physician associate himself, to describe what he thinks a graduate physician associate is able to do in primary care, rather than me.
Thanks, Ben. I think what's important that Ben alluded to is there is still a lot of mystery in terms of the role of the physician associate. And I think for any GP partners or anybody listening who are thinking about taking a PA, naturally in my bias element as a PA, I'd say do take them on. But what I'd say is there's a bit of resource and effort that needs to be put initially. Yeah. And sometimes, honestly, I'm dumbfounded when I hear some people hit back and say, oh, but what do you mean they can't do this straight away? And my response has to be, GP trainees have 3 years in order to practice and get to a level where they feel competent. Now, for PAs, we're not asking for the same time, because we understand that we're a different offering in a different model and way of working. However, there needs to be a bit more intensity in terms of supervision and understanding in at least the first 3 to 6 months. And what I would say is, the more effort you put in initially, the more you will get out of the PA. I cannot emphasize that enough. And actually, you can see that in PAs who have been given that initial effort. So really, the thing is that if you're employing a PA, the practice has to ask themselves, do they have that capacity? I think that's an honest conversation that you have to have. And again, a lot of it is around educating themselves. And if they don't understand the role fully, I think it's our place as hubs and various other institutions involved to try and help educate them. Now, we understand they're very busy, but I suppose that ties in. This is a bit off, but I think with PAs, there should be connectivity around from the training at university through to training hubs and also HE. There needs to be a real linear link about what's going on and some progression. So I think I've heard stories of certain PAs be asked to do certain things in the first few weeks, in which it drives their level of stress and anxiety. And some of them, it's their first ever job, and they internalize it and say, am I not good enough? But really, I feel like saying to, just shaking them and saying, no, this is impossible to ask for anyone.
James, at some point, when the stress that PAs feel when they go to practices, and how when you're talking to the supervisors and the PAs that are being supervised, coming back to that element of trust, there's a trust in the new PA that they are clinically capable, but supervision is a two-way process. And what also seems to be a mechanism that supports the PAs is developing a trust that the supervisor that is taking some responsibility for looking after them, for ensuring that the clinical management is appropriate and that it's feasible and pragmatic. And actually, the physician associates in a really stressful environment, and they need that trust and that relationship, because if they are being asked to work beyond what's the scope of practice is because of an unfamiliar supervisor, then unless they can sort of find a way of saying, I really don't feel terribly comfortable with this, and I'm feeling quite comfortable with that because of that trust, it's incredibly stressful for them. And they are still the employee. You go as you're a new employee, you're trying to impress, you're trying to settle in. And I think there's this sort of a discussion about taking some of the uncertainty off the physician associate, not letting them go home, with it all in their heads, and actually supporting them. And what my research is finding, that if that trust develops early and you can actually put some time in early, then you can get a very, very rapid growth in the physician associate serving that particular practice and those needs. And it may be slightly different from another practice, but the good quality supervision early can pay huge dividends, even 6, 9, 12 months down the line. And that's where I think it's important that both HE and networks recognise that it might be a short-term cost. And we know there's challenges in workforce, but the gain can be huge.
I think from what you're both saying and what I know in my own experience as well is there has to be that realisation of you have to put in investment in your new physician associate up front, and you'll reap the rewards down the line when that physician associate stays in your practice and working with you and knows your system and is really, really efficient with you. But it can be difficult in those first few days. You can't expect them to come out and work at the same level as a GP on day one.
It's about growing your own, and it's about you recognising that if you tend the small plants, they will grow and they will blossom.
Yeah, what's quite interesting actually about the stress, I think that for some PAs, particularly in GP, there is a sense of, as soon as you join, directionlessness, as in you're unaware of where you're going. And there's a real interesting paper that was done by Howarth et al. Around stress levels for PA students, around a lot of the unknowns and being in environments that aren't necessarily welcoming and understanding. Now, that's a good piece of research, but I think where the research really needs to be focused on is actually how are new to GP or new to hospital PAs dealing with this? Because I have to say, because some of them are into roles where sometimes the practices don't know, there's not only an expectation for you to succeed at your role, but really, what is your role? And for you to explain to them and to define them. And actually, that's not really fair. If you think about it, as a doctor, as a nurse, you don't need to explain the role. But if you're having to explain the role, navigate through your first couple of months, it's an incredibly challenging environment. And I'd love to know your thoughts on that, James.
Yeah, I would agree. It's very difficult to know whether you're doing the job well or not, because you don't always know what the job is, especially if you're the first PA into a practice. And unless you have some very forward-thinking supervisors around you who know what they want you to do and what is a realistic expectation of you, I can see how that would be incredibly stressful to go into a different environment like that. And my heart breaks when I hear of people leaving their jobs really early on or not getting the right support in the right time.
One of the most famous models of supervision is from Bridget Proctor, and it has three areas. It has the sort of accountability, debriefing, is the person safe and following the normal guidance. And of course, I think when you're a new practitioner, you want to sort of establish both the supervisor and the practitioner. That's your first thing, to establish, can I operate safely within my role here? And then we've talked a little bit about dealing with stress and that trust and having the back. And the other part of that model is a restorative, a support model, dealing with the stresses in a new role and things. And what Javi was saying about not knowing really where you're going links to the sort of formative element of supervision. We know what a doctor looks like. We know what if you have a medical student in your practice, you're a doctor, you know roughly what it's like to graduate in medicine. If you have a training doctor in your practice, training GP, you know what a fully fledged CCT in general practice is. If you have a new PA, and this is relevant for other advanced clinical practice roles, it's difficult to provide that formative mini kex cot that Javi's trying to put there if you're not quite sure what the destination is. Because where are your sort of benchmarks for where that practitioner is going? And I think that's a big hole in the system. But what's important is what the benchmark is for where those practitioners are expected to develop and in what areas.
I think as well with physician associates, it can be scary not knowing what you're supposed to do. There is also beauty in being able to tread new ground and blend across different ways of working and create new pathways that you can't always do as a doctor. But it certainly comes with its difficulties as well, doing it that way.
Yeah. But just a bit that I'd actually like to bring in terms of, about a preceptorship or a new role where you're growing. Actually, I don't think the education is the most important. And I think where more effort needs to be put on is providing support groups and networks. So some people talk about, and again, not to use the doctor model, but they talk about like CPD local networks. And sometimes when you're the only PA in a practice or in a patch, actually what's more important is connecting with other people on a regular basis to discuss what's going on. And we mentioned earlier about career progression. And actually career progression should not be dictated from the top down. Actually, it's bottom up. And really what we should, all of us throughout the country or even throughout, the UK should be looking to foster is some form of what does our job look like? What does our role look like? What do we do? What's a good aspect? What's a bad aspect? If someone's coming new to the role, what do we think an adequate job spec is? What is career progression for a PA? Because I think at the moment, a lot of it's being dictated by those up down, and not because they're not interested in what we want to hear, but because it's so unknown and they feel the responsibility to be able to shape that. So that's why I think actually we should really be pushing support networks. I want one in South Yorkshire. I want one in Yorkshire. I want one in every part of England. But again, I think all of us need to do it together.
Yes. So I suppose one of the things when you were talking about buddy and support networks that came into my mind was around the First 5 scheme, which is something that GPs tend to have in their first 5 years of qualification as they become new general practitioners. They have a support network of sort of social support and peer support of people that they've trained with in the local area. They get together maybe on a every 2 month kind of basis, usually away from work in their own time, but they have that sort of constant like peer social interaction where they just check in on each other, check that how they're doing and how they're progressing against each other. And if they want to bring any difficult cases, they can, but it's not really the primary clinical focus.
And the first 5 network has now been almost formalised in the GP mentoring. The first 5 group was a sort of an organic group that developed from and led by the college as well, that developed for the need. But now the actual investment within the NHS primary care is giving those new practitioners. So there should, similar to the what you're doing in the PAs, but and that sort of mentorship, that sort of peer networking is important and for those GPs. So it's now there for GPs and for the practitioners. It should be there for PAs as well.
Becomes a sort of praxis group of support.
Yeah. Community.
Yeah. So James, you answer exactly. Yeah. Something along those lines. It doesn't have to be exact. Why does it have to be just PAs? It'd be wonderful to have some advanced nurse practitioners and other healthcare practitioners. In fact, I'd love it.
Multidisciplinary.
Some of these. Yeah, because there's so much we can learn from them as well. And I don't think there's like a us and them. I see all of us together.
I agree with what you're saying. It's a great ambition. I just wonder how we make it happen and who pays for it. But
just to sort of say that what the PA scheme is doing in South Yorkshire is a programme of work from the South Yorkshire Primary Care Workforce Hub, which is actually doing its very best to use the money that has come into various levels in the NHS to build the architecture that will support practitioners in a multidisciplinary way and in an equitable way and in a way that deals with health inequities and tries to support practices that are struggling because with workforce, which are often in the most difficult places to practice due to complexity and multimorbidity and things. So the very essence of what the South Yorkshire and Bassetlaw Primary Care Workforce Hub, which is part of what Javi is doing, is to try and develop something for the region that makes it a special place to come to work.
Thanks so much for joining me on the podcast, both of you. If people have listened to this and have got questions about what we've spoken about, what's the best way for them to get in touch with you?
Thank you very much. So if anybody's got any questions about, what as a PA or somebody that's looking to hire a PA, or what a preceptorship program might look like, you can contact me on javadil.islam1@nhs.net.
And if anybody's interested in the research I'm doing and the new roles in primary care, then they can contact me on ben.jackson @sheffield.ac.uk.
Thanks both. And I'll leave links to your contact details in the show notes. So for anyone listening, they'll be able to find your contact details there. And I hope you found that really useful to listen to as well. If you've got any ideas or topics for future Physician Associate podcast episodes, if you'd like to come on the podcast yourself, please get in touch. We're on social media at PA Podcast UK. And I hope you'll join me again next week for the next episode.
Thanks for listening to the Physician Associate podcast.